이 언어 to be
So it'll make sense, but effectively we were making fun of somebody else when we wrote this. And for the record, I dislike PowerPoint and everything it stands for, but this is the way we have this to present. For kind of rules of engagement when getting people moving. And these aren't rules, these are trigger words for you to go, I've heard this word before. What do I need to think? Sad face. If you have enough words that say sad face, you're like, I need to be careful. And that's the point of this. So 11 reasons to be careful with early mobility. All good? Oh, I've got to click that one. So, blood pressure. We've all talked about blood pressure, high or low. So, kind of vague lines in the sand is a systolic of less than 90 or a systolic of more than 180. Now, I wrote this, I think, maybe 15 years ago, give or take. And if you look on the between the flags charts, they're exactly the same numbers. Somebody asked me for a reference, and I went, I don't use a reference. This is just the numbers I have in my head. But if you look in the intensive care manual by O, it's in there. And if you look on the between the flags, those are your be worried kind of lines in the sand. So nice and simple. If somebody's got those numbers, you probably want to talk to the team. So nice, easy triggers. Septic, what does sepsis mean? Infection. So what is an infection going to do to your blood pressure? How? Does what? So inflammation does what? Dilates. If you have a swollen ankle, is that because there is more blood or less blood there? More. So do you have dilation or constriction? Yeah. So if you have dilation systemically, and that's what septic shock is, what happens to your blood pressure? It goes down. Yeah. And then do you feel a bit fainty? Yeah, just think how you felt. Yeah. So if you are hurting everywhere, you have inflammation everywhere, and then you have vasodilation everywhere. Yeah, as opposed to locally. Yeah, you're not going to get a low blood pressure from a big toe problem, but if the problem gets systemic from that big toe, then you will have systemic vasodilation. Yeah. So again, back to first treat the problem. If you've got an infection, what do you need? Antibiotics, and then treat the blood pressure, which we'll get to in various ways. Hypovolemic shock, what does that mean? Yeah, low blood volume. And why would you have low blood volume? Bleeding. And how would we know somebody's bleeding? Low hemoglobin. Yeah, and what's the other way you would have a low blood volume? Dehydration. So the rate of fluid coming in versus fluid coming out. So if you aren't drinking anything because you're not drinking for whatever reasons, is that going to lower your blood volume? What's some common causes of too much volume out, other than bleeding? Diuretics, yeah. There are those people that, need to look good for Friday night and take too many diuretics. Make you pee more. What else? Diarrhea, yeah. Another classic one. Vomiting and diarrhea. Food ain't going in, water ain't going in, plenty of water's coming out. Yeah, hypovolemic shock. Being out, running in the middle of the day in the middle of summer, because, runners. Classic hypovolemic shock, leading to rhabdo, leading to, welcome to ICU. So inotropes, these are words you'll see, and I don't expect you to understand any of this, but we'll go through them with patients in the ICU and in the cardiothoracic ICU. But noradrenaline, does anyone remember what noradrenaline and or metaraminol are for? Yep, to do what? Thinking we're in blood pressure, so up or down? Up. So if the problem is vasodilation, the solution would be vasoconstriction. And if the solution is vasoconstriction, that's what those first two ones do, peripheral vasoconstriction. Inotropes are way more complex than that, but for our purposes, if you see noradrenaline, you see metaraminol, it's a blood pressure low problem. Yeah. So what's going to happen if you stand them up? Yeah. Do we want them to faint? No, and that's what we're being careful of. Now, you don't have to say zero NORAD or zero metaraminol. You guys we've dealt with patients. What's our kind of line in the sand? Yeah, 0.05 of NORAD, 5 mils an hour in the old scale, or 5 mils an hour of metaraminol. Yeah. Above that, we're probably not going to do it unless we have to. Yeah. So we had a patient, she's neuro-y, she's 5 out of 5 everything. We took her for a walk on 0.03 of NORAD the day before. The next day she's on 0.08 of NORAD. Are we going to take her for a walk? No, Because we have nothing to gain. Yeah, she has no rehab goals other than not dying in the ICU. That's it. Wait another day. And that's the point of this. Wait till the afternoon, wait till the next day. So we looked at her. She wasn't good in the morning. She was good in the afternoon, below our number. We walked her. The next day she was back up again for various reasons. So we just go accordingly. Yeah. Dobutamine you'll see a bit more of in the cardiothoracic ICU. Imagine it's training day and you've just done legs. Yeah. How do your legs feel for the next 2 days? DOMS. And when you try and go downstairs, is it fun? So apply that same concept to somebody's heart when they've had heart surgery. Yeah? You reckon they got some heart DOMS? Is the muscle going to be a bit weaker before it gets stronger? Yeah. So the drug to make your contractility stronger is dobutamine. Yeah? So it's to bridge the heart DOMS. So any reason why somebody has a weak myocardium, dobutamine is a contractility agent. Again, more complex than that. And adrenaline they would use in other places instead of either noradrenaline or dobutamine and so on. But adrenaline is panic. Yeah. So if somebody has no heart rate, can you give them a heart rate with adrenaline? Yeah, that's all. If somebody has a low heart rate, has a low blood pressure, adrenaline does those things. What's the other common use for adrenaline? Or epinephrine? EpiPen. Yeah. EpiPen. And why do you get the EpiPen? Allergic reactions and anaphylaxis. Not just a low grade, I've got a bit of a rash, you don't rub adrenaline on there. But if your airway and all's closing over, so adrenaline's effects in different places are dilation in some places, constriction in others. So if you have edema in your airway, angioedema, that's your anaphylactic reaction, what's going to happen to you? Will you live or die? Because resus is airway, breathing, circulation. So you get the EpiPen to cause vasoconstriction in these bits. Yeah? And that will reduce edema. Now, what is the effect of adrenaline on your lungs? Yeah, so that's more brain, but the actual lungs themselves. What would be a beta-2 adrenergic receptor agonist? Yeah, asthma puffer. What's the drug? The brand name, what's the drug name? Salbutamol. Yeah, beta adrenergic receptor. Yeah. So what's the effect of adrenaline on your lungs? Bronchodilation. And does that sound like it'll make it easier to breathe? Particularly if you're finding it hard to breathe. And again, in panic, do you want to breathe more or breathe less? Breathe more. So more open airways, more respiratory rate. What's the effect of adrenaline on your heart rate? Increase. What's the effect of adrenaline on, say, your peripheral blood flow? Peripheral? Increased. As opposed to your middle section. What do you want more or less blood going to your gut? Less. So adrenaline alpha effects are going to be a vasoconstriction in your gastrointestinal areas. And does that sound like ischemia? Yeah. And how does that feel when you're having the adrenaline response? No, that's if you are doing too much cocaine. Again, a bit of an adrenaline response. Not chest pain. You know the good old butterflies in your stomach kind of saying? Yeah, what's that? Adrenaline. What are you getting? A vague sense of ischemia. That's what that feels like. Yeah. So if you have like a cervical spinal injury and you don't feel that, you don't have the brain response to adrenaline. You've all seen those dudes playing murder ball, right? Does that sound and look terrifying? Yeah, they're not terrified. They have no sense of fear because they don't feel the adrenaline giving them the sense of fear. They don't sense their own heart rate and that kind of stuff. That's all. Swan-Ganz catheter or pulmonary artery catheter. Again, you will see this in the cardiothoracic ICU. So it is for cardiac sad face, particularly after surgery. And it's often there to measure the effects of these drugs we just talked about because they'll be on a couple of them sometimes. High blood pressure, because I had to give it a number, and we discussed the other day. I said, what's your number to one of the guys? They said 180. I said, yep, good enough. Do we move people on more than 180? Sometimes, but be careful. Yeah, it's a risk reward. Like if the risk is that staying in bed is bad for them because they're post-op abdo surgery, then you probably want to move them. Other part of that is if you've had surgery, are you going to have some pain? Is pain likely to make you panic? And is that likely to put your blood pressure up? So what do they actually need for the pain? Heroin. Whatever version of heroin they're getting. Yeah, does that make sense? Is pain going to make your heart rate up higher? Your respiratory rate higher? Yeah. Again, when they've had their chest cracked open, they'll breathe like a goldfish. Literally, if you see that, they need pain relief. Yeah, you've all seen what a fish looks like when it's trying to breathe air instead of water. That look. Well, in the short term, nothing. Gets you away from the thing that wants to eat you. But in the long term, have high blood pressure for 20 years. What are you going to die of? Heart or stroke. Yeah, that's all. Short-term gain, long-term problem with everything. Back to what I was saying before. Prevent all of this, what do you die of? Cancer. Bleeding. So we mentioned before hemoglobin. So back to a thing I learned decades ago. When you don't know how to interpret bloods, check potassium, check hemoglobin. At least that way you've looked at the electrolytes and you've looked at whether they have been bleeding or not bleeding. Particularly post-op, particularly like ortho surgery and a few other things where you wouldn't expect. So that came to me from the ortho team, and I, to this day, 20-something years later, I check potassium, check hemoglobin every day. So our line in the sand for when they're going to get a transfusion is 70 in a medical patient and maybe just below 80 for a surgical patient. And again, it's personal preference on the doctors at the time. What is the purpose of hemoglobin? Carry oxygen. And if you don't have enough hemoglobin, will you be holding enough oxygen? No. But will your sats be fine? Yeah. You'll be saturating less hemoglobins, which is not a sensible way to think about sats. But yeah, less hemoglobin is less oxygen carrying capacity. And what will that do to your ability to do work? Yeah. And what will it do to your blood pressure? Decrease it. Sad face. So it's not that it's illegal to move somebody while they're getting blood. It's just you'll get more work out of them after than before. So wait the 2 to 3 hours it takes. That's all. Platelets, they're just there because just be wary of bleeding issues. It's not a contraindication, but people will have cannulas and all sorts of other holes in them. And we've talked about this, thrombocytopenia before. The idea is just be as careful as you are with everyone, and then you don't have to be extra careful. Yeah? Make sure your cannulas are secured and you've untangled the person like we do with everybody. Broken-hearted. So, what is troponin? Protein, tropomyosin. And tropomyosin is found in striated muscle. And one of the strands of tropomyosin is the T, which is found specifically in cardiac striated muscle. So if it's found in your blood, has it left the muscle? Yeah. And if it's left the muscle, there is muscle damage. So it doesn't happen instantly. Yeah. And when you have muscle damage, it takes some time for the proteins to leak out into your blood. So if you come in with chest pain, they check you at time 0, then they'll do another test at 8 hours and at 24 hours. Yeah. And what you want to see is a kind of curve that goes up and comes down. Have problem, see troponin, treat problem. So if you see it's still going up at 24 hours, are they having ongoing problems? Yeah. The other classic time you'll see this is after cardiac surgery, because obviously somebody went like that to your heart. But that will be maybe 1,000 to 1,500, and it shouldn't be 7,000 because then something's gone astray, or along those lines. So ECG changes. I just mentioned this to say if you see the word ECG in a sentence, be careful. Check their troponin. What does the STEMI stand for? ST elevation, yeah. And what do they mean by ST elevation? Yeah, so just the classic change that you get in males having a left anterior descending blockage, as opposed to a non-ST elevation, yeah? Myocardial infarction. ST changes don't mean myocardial infarction in that you can have one without it, yeah? And back to, if you have the ST changes, then that's pretty obvious, men or women, but if you have the non-ST changes and you don't have the classic symptoms of a man, and you're a female coming to ED, you might not get treated as accurately. We discussed this the other day, and I need to properly learn this and properly explain this, but what I really need you to understand is that the letter S is part of your QRS, and the QRS is what part of the heart, the top or the bottom? Yeah, the ventricle, the thing that does the job. Yeah, and what's the letter T, the top or the bottom? Bottom, also ventricle. So the letters S and or T, do they mean ventricle, sad face?
Yeah.
That's the most important thing. S and T equal ventricle, sad face, if you see them in a sentence. This is why I don't want you writing unnecessary things. Don't write no ST changes if there is nothing wrong with them. Yeah, just because there could mean, yeah, just don't write things that confuse people, and certainly acronyms. So cardiogenic shock is another one of those kinds of shock which we'll go through in Heart Week. But the idea is that your heart muscle is weak for some reason. If your heart muscle is weak, what happens to your blood pressure? Decreases. And does your heart require blood pressure for your coronary arteries? Now, one of the extra tricky things is think about a heart muscle. When it contracts, is that systole or diastole? Systole. So during systole, you have a good systolic pressure, but the coronary arteries, which are over there somewhere, they're getting squashed by the muscle. So can blood flow through your coronary arteries while the heart's contracting? So blood will only flow during the relaxation time, which is diastole. So your coronary perfusion pressure is more like your diastolic pressure, yeah, as opposed to your mean arterial pressure. So if you have a low diastolic pressure, you have a low perfusion of your coronary arteries. And then what happens to oxygen delivery to the myocardium? Yeah, what happens to the, putting of energy in and clearing out of metabolites? Yeah, and then are you going to ceviche your heart? Yeah, slowly, as opposed to a blockage, which is quickly. Yeah, but a blockage could cause an ischemic area. And then if that bit of the heart isn't moving, is your ventricle going to work as well as it should? So how would we look at somebody's heart without cutting them open? Ultrasound, yeah. TTE, transthoracic echo, or TOE, transesophageal echo. They literally get you to swallow the ultrasound head, and they can look at your heart from behind, so your sternum and your lungs aren't getting in the way. Yeah. So IABP, intra-aortic balloon pump, it is what it says it is. So intra means inside. Aortic means aorta. What does your aorta do? Not pumps. The ventricle pumps. Carries blood from the, which one? Which side? Left ventricle to all your organs. Yeah, it is the pathway. And then balloon is literally a balloon, like one of those sausage dog balloons. And pump means moving. So why would you need this pump? Because what isn't working? Which ventricle? Left ventricle. Yeah. So have a bad enough cardiogenic shock and you get the balloon pump. When the drugs and so on aren't working. So what is the drug that helps increase your contractility? Oh, dobutamine. And no, this is why we're here. You're here to learn these words maybe for the first time, but just to cite them and go, that word, sad face. Cool. When are we going to be happy? When there is less of that word. So dobutamine may help and various other things help, but fix the primary problem. If it's a coronary artery, fix the coronary artery. If it's an infection, you can have infective endocarditis. Infection in heart, sad face, itis. Yeah, that's the way to think about this. So you will recover from those things, but they take time. And do I want to make sure there's enough blood going to your brain during that time? And do I need to make sure there's enough blood going to your kidneys during that time? And that's what the balloon pump does. And again, we'll talk about kind of how it works when we look at one, rather than as some weird esoteric exercise. Brain explosions. So the number 2 killer, heart number 1, brain number 2. So acute ischemic or hemorrhagic event, which we've seen a few in the ICU. If you have, what is your signs of stroke? Fast, facial asymmetry, arm weakness or uncoordination. S is for slurred speech or lack of speech, which is dysphasia, or jumbled words, dyspraxia, or the slurring, which is dysarthria. Yeah, which won't kill you, but the dysphagia, the swallowing one will. So they all go together. So you have any of those signs, and T is for time. They get you to a hospital, and they get you into a CT scanner. And if it's an ischemic event, what is the likelihood of it being ischemic versus hemorrhagic? To be ischemic, yeah, 80-20, give or take. Yeah. So hemorrhagic would be a bleed. So what would be a sign on a CT scan that somebody's had a bleed? You need the angiogram for that one. So what color? So thinking about X-ray, yeah. What is more dense in terms of X-ray colors, black or white? Yeah. Bone. What is less dense? Air. What's in the middle? Water and other stuff. Yeah. So you've seen on an X-ray that the bone is more dense than the water. Yeah, the heart and stuff. So thinking about a bleed, what is more dense, blood or water? When blood is coagulated. Yeah. Hemorrhage and hematoma, does that sound like blood's coagulated somewhere it shouldn't? So if you see white stuff that shouldn't be there, hemorrhage and hematoma, yeah, outside the blood vessel, hemorrhagic event. Whereas if they have an ischemic event, that's words like thrombus and embolus. You might not even see them because they're very small. Yeah, and if you get to somebody into a CT scanner early enough and you haven't killed any brain cells yet, you're going to have the inflammatory response? No. So you won't see anything sometimes. So if you don't see a bleed and they have the stroke signs, is it best to assume they have had an ischemic event? And what's the treatment for an ischemic event? TPA, tissue plasminogen activator, which is a thrombolysis. So back to the words thrombus and embolus. If they've had a bleed, you want to give them thrombolysis, because what will that do to them? Yeah, and that's it. And you need to do this very quickly because time equals brain. Yeah. And the other version is the endovascular clot retrieval, which they go in like they do an angiogram and just unplug it, and that restores blood flow pretty well. Yeah. I need to add that too here, but sufficient to say they're usually less of a problem. They have the CT scan the next day and we proceed with them. If they've had TPA, then they're on bed rest for 24 hours, and then we play with them after that. Why is that? Maybe. Yeah. So that's why you want to see the repeat CT scan. But even if they've had the repeat CT scan and there's no bleeding, it's if they did a study where they were early mobilitying people, because, you know, if something is good, then doctors say more is better. Was more better? How do we know? The paper says increased mortality. Do you want to have increased mortality? So don't mobilize people less than 24 hours, particularly the ones that look absolutely fine. Yeah. If they are 5 out of 5 everything, are you actually achieving anything by physioing them? Can you give them some problems, i.e. increased mortality? Yeah, that's all. Early mobility, earlier rehab the better, but just not too early. Yeah, yeah. No, and again, like, you know, like we always do, check the numbers, start with sitting balance, go from there. What's the other thing we want to check before we sit somebody on the edge of the bed? Well, they're the numbers, but what else? Physically? In what way? That's the actual test. You're testing them by sitting them on the edge of the bed. What am I doing? Yeah, because what's the problem if I can't do this? Sublux dislocation, so what do they need? Sling. And beyond that, don't care. Yeah? If they can move or not move, doesn't matter. You're rehabbing them as early as possible anyway. Yeah? A thing that I got taught, because I didn't do any rehab ever, from the neuros when I was the ICU senior was, Nick, why aren't you working on sitting balance? Because it's boring. And they said, but they need sitting balance to go to rehab. And I went, oh, if it helps them get to rehab, that's it. That's the first thing we do. And we do plenty of that until they have sitting balance. Yeah. So if you have sitting balance, can I sit you in a chair easily? Yeah. If you don't have sitting balance, is that going to be as safe as... No. So what do? Slide people into those water chairs that are a bed without pressure relief. I do not like them. If you see me using one in the ICU, it's because I don't like the doctors. Yeah. Everyone knows that. Why are you doing that? Because I don't like them. They are just a bed without a pressure relieving mattress, as opposed to our beds that go fully into a chair, because this is ICU and we have the technology. It's 2021. Head trauma, we don't see a huge amount in Prince of Wales, but obviously trauma's trauma. The bilateral black eyes, classic sign that somebody has a base of skull fracture. Don't stick anything in their nose. Yeah. And what's some things we might stick in somebody's nose? That's going to be just in the nostrils, but deeper. That too. So be careful of that. The nasopharyngeal airways if we need to suction somebody. Yeah. So if you do, because these people can't remember, back to dysphasia, dyspraxia, and dysphagia. You reckon they're at risk of reflux and or aspirating? And is that your job to clear that out? Yeah. So intracranial pressure, extraventricular drains. They basically have to sit at a certain height above the patient, which limits our ability to get more upright. Seizures, if somebody's having seizures, I usually wait 24 hours for them to have stopped having seizures so that they don't have a seizure while you're trying to walk them. Yeah? Do I have any paper that describes that? No. But that comes from getting it wrong and therefore going, how about we wait a day? That's all. So coiling, clipping, endovascular clot retrieval, all the interventional neuroradiologist stuff, like, you know, any of the surgeries, you'll have post-op orders. and a post-op CT to check things and so on. Just wait till those things are done. Because again, sometimes in these people, once they fix the bleed, they've coiled or clipped the aneurysm, they might actually want their systolic to be 180 and above, because a later down the track problem is vasospasm. So you think, well, I don't really want them to have a systolic of 200, but the doctors do, and they can move, and it's a fine line. It's just words to indicate that you should go check with the team what the plan is. This one. Blood thinners. Not. Don't call them blood thinners. You want to thin somebody's blood, add water. You want to thicken somebody's blood, dehydrate them. Or add, as we talked about yesterday, more blood, i.e. EPO, or too much EPO. Somebody that doesn't need that much EPO because they're already altitude trained. So DVT stands for deep vein thrombosis, and if you have a clotting problem, then you get anticoagulated. Yeah, and the fastest way to anticoagulate you is with heparin. And your heparin has a clotting time, and then if you are therapeutically heparinized, then your clotting time, the APTT, is 45 to 90 seconds. Activated partial thromboplastin time. Yeah, I have to memorize that for some reason, but it's not important. Sufficient to say, therapeutically anticoagulated, usually you can proceed with doing things. Now, heparin is an IV drug. Is that okay to push an IV pole and walk them around? Yeah, as long as the other numbers are okay. But do they want you to be attached to an IV for 3 to 6 months? So what do they put you on that's a tablet? No, much more hardcore, but ends in in. Starts with a W. Warfarin. And there's new ones like clopidogrel and all these other, like new age something. NOAC, whatever that means. I call it new age anticoagulation. Anyway, they are on something that's a tablet. Yeah, and once they're on that, all's well. So the test for somebody on warfarin is an INR. It's effectively the ratio of what you are to what you should be. So if I tested any of you, you would be 1, give or take a little bit, and the therapeutic range is 2 to 3. So again, if your clotting time is more than 150 seconds for APTT or more than 3.5 times longer to clot for warfarin, they might bleed. Be careful. Wait till the numbers go back to normal. Because really, the solution to that is just stop the drug, and it comes back to where it should be. A PE is not a problem in that once it's in your lungs, it can't go backwards. No matter what anybody tells you, it cannot do that. The cause of the PE has to be worked out. So if it started in your leg, could there be more than one? Yeah. And if it started in your atria, which we'll talk about in Heart Week, could it go from the right atria to the right ventricle to your lungs? Yeah. Could there also be a problem in your left atria? And that would send something to the left ventricle and then to your brain. But pulmonary embolus. But the pulmonary embolus can't go backwards. Once it's there, it can literally, there's a pressure gradient. It cannot turn around. So the PE can't cause a stroke. The cause of the PE has to be a very strange set of circumstances to get from your leg to your brain. Not common. The cause of atrial fibrillation causing stroke is very high. A PE? Nothing. Unless your PE is so big it stops blood going through the circuit. In which case, are you walking around or getting CPR? And watching somebody get CPR, does that contraindicate mobility? They're already getting plenty of chest physio.
Fantastic concentration.
Exactly. Well, you've seen us assist cough people. It's like CPR, but you push harder. Bones. Weight-bearing status. Yeah, your ortho patients. Now, the problem is, ortho are pretty good with this, I've got to say, but like vascular are very painful in writing proper mobility orders. Strict bed rest, okay for toilet privileges. What does that mean? Yeah, like, do you want us to stand them on the unaffected leg and then sit in a commode chair and get wheeled there, or are they allowed to take a few steps? And then why write strict bed rest? Upright orders post-spinal surgery. Again, if somebody has surgery, usually of the spine, they'll do like a repeat CT scan to check that the hardware's in the right place. Many people will tell you they don't check the hardware. I check the hardware. Why? Because the hardware can be in the wrong place, or the hardware can break. And at least you know you broke it or didn't break it. They can't blame you, because hardware breaks and hardware moves and hardware might not have been in the right place to begin with. And if I could show you these, I have a screw tapping on somebody's aorta. So yes, that's why we check the scans before. Orthotics, so collars, turtle brace, like TLSO and all that kind of stuff. You know, bed resting, whatever, foot drop splints, all that kind of stuff. Have the appropriate equipment. Because we get a lot of spinals here, so it's, do they need a collar, not collar, whatever. The things, orthotics come and sort that out. Any questions on that one? Yeah, so the pain in your ass will be the fact that ortho documents something, another team documents something else, and now they can't stand on either leg. And both of them are angry at you because you didn't mobilize the patient, but haven't talked to each other. It's like, well, their right leg's busted, but their left leg's vascular, and so on. Or non-weight bearing left leg, touch weight bearing right leg. Yeah, can that actually be possible? Most of you couldn't do that. Yeah, there's always somebody in here that can, frickin' it's the Roman rings thing themselves from a sitting to a standing position. I can't. That's all. You got to be like a hardcore climber to do that. Brady tachycardia, again, just the sensible numbers. Heart rate low, heart rate high, heart rate max, all those things. But the number itself is partly important, but the number relative to where they were this morning or yesterday is actually more important. Because if somebody was normal and now they're tachycardic, has something sad face happened? Yeah. Whereas if their heart rate was 130 in rapid atrial fib yesterday and it's the same today and it's the same again tomorrow, and they're not dead, are they okay with it? Yeah. And if they're post some kind of surgery, waiting more than 2 days, is that going to be bad for them to mobilize? So graded mobility and be careful, keep monitored. That's all. So heart rate reserve is that equation. As a simple line in the sand, something more than 20 is better for you if you want to walk. But if you're just going bed to chair, just keep them on the monitoring. And the other simple version of this is if your heart rate is higher than your systolic, that is not normal. Yeah, your systolic is 120 and your heart rate is 70 to 80. That's normal. Just think about you, think about them. If their heart rate is 120 and their systolic is 90, something bad's going to happen because they have nowhere to go in terms of coping with changes in position. And obviously, if they're in an arrhythmia, it's different. How do you know they're in an arrhythmia? Do that. If it feels like a nice even beat, they're in a nice even beat. If it feels uneven, they're uneven. It takes about 4 seconds to work that out. If you can tap out evenly in your head, which many people can't. If you can do that one, tap your head and rub your belly. Breathlessness. So as we talked about before, how do you know somebody's short of breath? Number of words they use in a sentence. They can speak in a full sentence and tell jokes. Are they likely to have respiratory problems? No. Nah, and that was our lady, even in Arabic. I could work out that she was fine. Didn't understand her, but she was fine. Yeah. Oh, yeah, exactly. So, check the SATs, check that the oxygen is actually in their nostrils, not on their forehead. Check that the oxygen is plugged into oxygen and not air, as sometimes happens, because patients do weird things, doctors do weird things. And that's all. We often, if you have somebody that is really struggling and on BiPAP continuously, just set up with the BiPAP on them like it's a Hudson mask and get them out of bed. It's not hard. You just can't travel far, but you can still travel. Because early mobility is good for these people. Early mobility is good for gas movement, good for sputum movement, and being in bed is bad for function. So the classic, give somebody with COPD too much oxygen, and what happens to their CO2? Increases. And if your CO2 goes up, are you more awake or less awake? Less awake. And if you're less awake, are you breathing more or breathing less? And if you're breathing less, what is your minute ventilation doing? And if your minute ventilation decreases, what happens to your internal CO2? And if your CO2 goes up, what happens to your GCS? And if your GCS goes down, what happens to your minute ventilation? What happens to your CO2? Yeah, going quietly in your sleep. That is a good thing. Somehow we try and stop that by physioing and doctoring and so on. But that is the literal definition of going quietly in your sleep. Yeah. Not a bad way to go. I don't know. Anyway, if you give somebody too much oxygen, they retain CO2 because they can. No matter what anyone else tells you, they do it because they can. How do I know? You can ventilate somebody, own their everything. You own every number about them, and they'll still retain CO2 just because they can. Yeah. Partly drive, mostly VQ matching, and a bunch of other stuff.
Exactly.
exactly. Bilious, norovirus. Wash your hands. That's all. Yeah, get the patient some if they need it too. It's like, well, you can imagine I'm giving this talk to new grads that are slightly hungover on a weekend. Yeah, go and talk to the nurse. The nurses in ICU are your friend. That's all. They were my friend when I was a junior. Vomiting. Bile. You know, bile? That's all. I had to make all these start with B. Yeah, 11 reasons to be careful. Ah, you haven't noticed that? Jesus, what's wrong with you people? You not study English or something. So, bilious is, yeah, bile, like those kind of things. Somebody's been vomiting, like one of our patients yesterday. She was vomiting and then she was having a nap. Did we wake her up from that nap? No. And when she woke up, was she happy to go for a walk? Hey, that's all. Come back later. Like, let them chill for a bit. You've all had this experience. Belligerent. Belligerent is delirium, dementia, and all those kind of things. And yes, because I can't call them cray-cray, I got told. I don't differentiate. Like, you know, when you're in ICU, it could be all of the above. It is all of the above. And you need time to work out which of the above that it actually specifically is. That doesn't matter day 1, day 2, day 3. That's a whole other thing. So people do get delirium because of infection. They get delirium because of drug interactions. They get delirium for a whole bunch of reasons because they don't want to do physio. They're in a new environment and all sorts of stuff. We get, you know, psych patients, overdoses, withdrawal. Those guys usually are fine after the first day or so of just, you know, chilling out or getting chilled out, and then they get up and try and run away. You don't have to do mobility with them. That's all. They will try and escape. Hallucinating where it affects their judgment. So the classic hallucinating is the trails of ants when people have opioids. Or as one person said to me, I said, how was your day? How was your night? All good except the nurse with the spiders in a bag. Does she have spiders in a bag or is that just the drugs? And he went, yeah. So your brain doesn't know the difference, yeah? That's all. The real nasty one patients have told me about is they can hear a phone ringing and nobody's picking the phone up. Yeah. That would be the worst. Yeah, and you aren't even necessarily awake, but your brain is just, you know, the good old pipe dreams from opium. Yeah, this is all the stuff that's going through their head, and their brain registers it as real. This is the post-traumatic stress disorder from being in ICU for too long. Don't end up in ICU. That's all. Exactly. And this was again for the new grads, written for you know, the weekends, where the doctors are like, oh yeah, I think they should get out of bed, and it's like, hang on, if me and Pete and 2 students couldn't stand a person up on a Friday, what is one new grad going to do on the weekend? And so, you know, for our juniors, it's like very much that sounds like a Monday problem lesson. And that's it. You know, you can't do a certain amount of things on the weekend because there's literally less people around. Again, our post-COVID patients with the critical illness, polyneuropathy, polymyopathy, it's basically like Guillain-Barré. They just literally can't move anything for 6 weeks until the mitochondria turn back on. I'm not pretending I understand any of that, but I just think about it as well. They have a mitochondrial dysfunction, which means ATP sad face, which means they can't do stuff. And if you can recover, you do recover, and if you can't, then you don't. And you don't know that for a period of time. So yeah, if somebody's like low GCS or eyes are open but nobody's home, they're not going to be able to follow instructions. You know, that's where you have to use your judgment on a risk reward. Like often, you know, because the patient is otherwise in a wheelchair for our spinal patients, then, you know, they would get hoisted into a chair, and sometimes the physios assist, and sometimes it's just the nurses and the surgical dressers. But yeah, if you can just be hands-on quickly, then that's not a hard thing. But yeah, it's just how much time you otherwise have to do all the other chesty things and so on that you have to do. And the pain. So pain is obviously a reason to be worried and be careful. Yes, that was 11 Bs. This is number 12. See? This is the 12th one. And effectively, if somebody has pain issues and they have the PCA, like, don't go and break the news to somebody, I'm getting you up right now. Like, if you know they've had, like, the TAH BSO, like, they've literally removed all the internals in a woman for cancer reasons, she will not be happy for anything for days with pain sometimes. Sometimes they get an epidural block. And an epidural block is really good at blocking pain, but then it blocks your responses to blood pressure. All these things, it's like, well, it's good for pain. Guy we had yesterday got epidural, couldn't feel his legs. Big unit. You reckon he's going to be safe to stand up? No. So what do? Not stand him up. Why? Because when Nick asked him to cough, he started crying. And then got in trouble from the nurse for making the guy cry. So they turned to turn his epidural back on. How that was our fault, I don't know. Our job is to ask you to cough and get you out of bed. Anyway, the four winds blew, the white foam flew, the fentanyl followed free. Rhyme of the Ancient Mariner. That's why that's there. Swap the B's for some F's. Yeah. So what is the solution to pain? Heroin. What's better than heroin? Fentanyl. In a metered dose that's medical grade. PCA, have them press the button, then go and find a chair and a sheet and whatever else, and then come back and they press the button a second time. Spend another 5 minutes untangling everything. And then when you're ready to get up, they haven't hit number 3 of their PCA, and you have cared for their pain, and you've told them you're going to care for their pain. So you've got the talk placebo, you've touched them hands-on placebo, they have the machine PCA placebo, and the needle placebo. All 4 placebos you could ever hope for, and also heroin. You reckon that's going to work better than not doing that? Does doing that take you any more time than not doing that? So always do that, yeah? Particularly day 1 post-op, the first time you see somebody. Go and break the news to them that I'm the physio, you may or may not have heard of me. And if they haven't heard of you, you go, somebody better have a word with your surgeon, because you should have been warned that I was coming. We come with the stitches, unless it's an emergency thing. Even more reason to do the informed bit of informed consent. Here's where you are, here's what I plan to do about it. I just need to work out a time frame that works with you. Yeah? Not do you want to get out of bed? Do you want to get out of bed? Did you want to get out of bed this morning? No. Straight up. Why are you here? Because you'd fail if you didn't show up because you slept in. That's it. Yeah? So what is your fentanyl? Failing. Or not failing. And so on. Does that make sense? Yeah. So anyway, that's me.
Why does ketamine